Welcome back to the deep dive. We're grabbing a stack of notes today, diving deep into a really important condition, Wernicke's encephalopathy.
Definitely important.
Yeah. And our mission, like always, is to take all this info, boil it down, make it really clear, high yield, perfect if you're revising or just need to get up to speed fast. We're going to cover the whole thing, what it is, the causes, risks, how it hits the brain, what else it looks like, who gets it, the symptoms, tests, treatment, outcome, all of it.
And it's so crucial because, well, Wernicke's is an acute medical emergency. That's the first thing.
Right.
Missing it, delaying things, it can lead to really severe permanent problems, often leads into something worse, actually. So yeah, understanding it is vital.
Okay, let's unpack that, starting right at the basics. What is Wernicke's encephalopathy exactly?
Okay, so at its core, it's an acute neurological disorder. Think sudden brain dysfunction. And it's caused by a severe lack of thiamine, that's vitamin B1.
Thiamine.
And yeah, worth saying again, it's an emergency. Needs fast treatment, otherwise the outcome can be pretty poor.
Got it. Now, I often hear about this classic triad of symptoms. Is that always there? Is that like the main thing to look for?
The triad. Yes,
Yeah.
It's certainly famous. That's how Carl Wernicke first described it way back in 1881. It includes ophthalmoplegia or nystagmus.
So eye movement problems.
Exactly. Weakness or paralysis of eye muscles or those sort of jerky involuntary movements. Then there's ataxia.
Coordination issues. Balance.
Yeah, problems with coordination, balance, often affecting walking. And the third is confusion, an altered mental state.
Okay.
But here's a really, really crucial point from the notes. High-yield stuff. You absolutely do not need all three of those to be present to diagnose Wernicke's.
Oh, okay. That's important.
It really is. In fact, confusion, that's the most common symptom you'll see. The diagnosis is mostly clinical.
Clinical, meaning based on the signs and the patient's situation.
Right. Recognizing the features in someone who's at risk, rather than just relying on, say, a specific test result.
That's a really key distinction. Not needing all three. I think that trips people up. You mentioned alcoholics earlier, but also other causes.
Absolutely. It's definitely strongly linked to chronic alcoholism. You get the poor diet often, plus alcohol itself actually messes with thiamine absorption.
Right.
But really, any condition that causes severe thiamine deficiency can trigger it. The notes mention these tiny bleeds, petechial hemorrhages in specific brain parts, like the mammillary bodies around the ventricles. That shows where the damage is happening.
And if it's not treated, you said it can progress.
Yes, exactly. That's where Wernicke's sits on a spectrum, often leading into Korsakoff syndrome. Korsakoff is basically the later stage. Chronic, often permanent brain damage from untreated or repeated thiamine deficiency. It causes really severe, lasting memory problems. So Wernicke's is the acute crisis. Korsakoff's is the kind of devastating long-term fallout.
So thinking beyond heavy alcohol use, what were those other causes of thiamine deficiency we need to have on our radar?
Well, the notes list several important ones. Just general malnutrition, obviously, but also specific things like anorexia nervosa, severe vomiting, like in Hyperemesis gravidarum.
During pregnancy.
Yes, exactly. And malabsorption problems, maybe after bowel surgery, that kind of thing.
That really does broaden the picture. Okay, so let's dig into why this deficiency actually happens and who's most at risk. What are the main triggers?
The single main cause is just, well, not having enough thiamine. Simple as that, really. But the risk factors tell you why someone might not have enough.
Right.
Chronic alcoholism is the big one, number one cause. And it's not just about poor diet, though that's part of it. Alcohol actually interferes with how the body absorbs and uses thiamine.
So it's like a double hit, not getting enough in and not using what little you get properly.
Precisely. Then you've got general poor diet, malnutrition, any condition causing malabsorption, think Crohn's disease. People have had bariatric surgery.
Bowel pressure.
Yeah. Conditions with prolonged vomiting. Eating disorders, anyone on long-term IV feeding, parenteral nutrition if they don't get thiamine added. Certain metabolic disorders too.
Wow.
And the sources even add a few less common ones. Chronic subdural hematoma, just general nutritional stress, AIDS, some cancers, dialysis, even severe heart failure.
That was a much, much wider net than you might first think. Okay, so we know it's thiamine deficiency hitting the brain, places like the thalamus, mammillary bodies. But how? How does lacking this one vitamin cause those specific issues, the confusion, eye stuff, coordination problems? What's going on metabolically?
Right. So thiamine is absolutely essential for several key metabolic pathways in the brain, pathways that produce energy, help brain cells work. Think of thiamine as like a vital spark plug for certain brain circuits.
Okay.
When you don't have enough, those circuits just don't function right. The deficiency leads to things like oxidative stress, problems with mitochondria, the cell's powerhouses. Essentially, those specific brain cells aren't getting the energy they need, and they start getting damaged or even dying off.
So the thalamus and mammillary bodies are particularly thirsty for this thiamine fuel.
That's a good way to put it. They seem particularly vulnerable to this energy crisis. The confusion, probably wide dysfunction, the eye movement issues linked to damage in the brainstem areas near the fluid spaces, the ventricles, and the ataxia. That relates to pathways controlling coordination, maybe involving the cerebellum, which also gets hit. It's that lack of metabolic energy in those specific spots that leads to the symptoms we see.
Got it. So how common is Wernicke's, actually, and who are we mostly seeing it in?
It's probably more common than the official figures suggest, especially if you look at populations with those risk factors. The notes give some pretty interesting numbers. It's thought to contribute to maybe 10% to 24% of dementia cases that are identified as alcohol-related brain damage. That's quite a chunk.
10 to 24%, wow.
Yeah, and concerningly, the incidence of Korsakoff syndrome, that later stage, seems to be going up.
It's rising. That's genuinely surprising.
Yeah.
And worrying.
It really is.
Yeah.
Overall, global prevalence of Korsakoffs is maybe around 0.2%, but it's much higher in vulnerable groups, people experiencing homelessness, the socially isolated older individuals.
Makes sense.
And here's something else from the sources that really stood out to me. The prevalence isn't necessarily directly tied to how much alcohol a country consumes per person.
Really? How so?
Well, they give this example. France, which has relatively high alcohol consumption per capita, has a lower estimated prevalence, maybe 0.4%. Compare that to Australia, with potentially lower per capita consumption, but an estimated prevalence around 3%.
That is surprising. What does that suggest?
It really highlights that it's not just about the alcohol volume. It's about those other factors playing a huge role. Nutritional status, access to health care, social support systems. It's complex.
That France versus Australia comparison really drives that home. Okay, let's get practical. Clinical side. What does someone with Wernicke's actually look like when they come in? What are the key signs and symptoms?
Okay, so you're looking for a range of neurological and cognitive signs. The big ones we talked about: confusion, ataxia, ophthalmoplegia, and nystagmus.
But remembering not always all three.
Absolutely not always all three. And remember, confusion is the most frequent.
So if someone comes in, they have risk factors, and they're confused, Wernicke's should be right up there on your list, even if their eyes and balance seem okay initially?
Immediately. High suspicion is critical. And because the diagnosis is clinical, based on spotting these features, plus a known risk factor, well, there are actually no universally agreed diagnostic criteria.
No standard checklist.
Nope. Which makes that clinical judgment, that suspicion, even more vital. Other symptoms you might see: vision changes like double vision, maybe droopy eyelids, specific gaze palsies when the eyes can't move certain ways. Memory problems can be profound, especially difficulty forming new memories. That's anterograde amnesia.
That sounds more like the Korsakoff's end of things.
It can be, or it can be prominent even in the acute Wernicke's phase, especially if it's severe or progressing. You might also get retrograde amnesia, losing memories from before it started.
And what about things like confabulation? Making things up.
Yes, confabulation is a classic feature, although often more established in Korsakoff's. It's like the brain trying to fill in the blanks, leading to these sometimes bizarre but confidently told false memories. You might also see telescoping. Recent events feel like they happened ages ago. And the general term encephalopathy just covers that overall altered mental state, maybe milder cognitive fuzziness.
Okay. And on physical examination, what might you find?
Well, initially, someone might seem somewhat alert. Maybe the vocabulary is okay. Social habits seem fine, despite the confusion. But look closer. You might find signs of nerve damage, usually in the limbs. That's polyneuropathy. Reflexes might be decreased or abnormal. Obvious problems with walking, coordination, muscle weakness, or wasting cachexia, that's severe wasting, can be a sign of the underlying malnutrition.
Cachexia just meaning really significant weight loss and muscle loss.
Exactly. It points towards that severe nutritional deficit. The eye signs are really key, too. Nystagmus, those jerky movements, is the most common eye sign, horizontal, vertical. Also, specific nerve palsies affecting eye movement, like a lateral rectus palsy. You might also find general signs of poor health. Low blood pressure, low body temperature, maybe a fast pulse.
It sounds like a whole constellation of possible signs.
It is. And it's worth remembering, sometimes people have milder subclinical episodes. The symptoms aren't as dramatic, which is why you need that high index of suspicion in anyone with risk factors. If you see someone with known alcohol issues presenting confused, nauseous, vomiting, tired, weak, apathetic, think Wernicke's. Even the sources say unexplained low blood pressure or low temperature should make you suspicious.
Okay, so diagnosis is mainly clinical based on suspicion and these signs. What about investigations then? What tests do we actually use? Are they to confirm it or more for ruling other things out?
Mostly the latter, yeah. The sources are clear. Primarily clinical diagnosis. Investigations help support it, assess how severe things are, and really importantly, rule out other conditions that could look somewhere, your differentials.
Right. So what are the key tests we'd run?
Blood tests are usually first up. A full blood count, FBC, look at the MCV, the red cell size, often up in chronic alcohol use, urea and electrolytes, UNEs, to check kidney function, sodium levels, calcium, liver function tests, LFTs, obviously relevant with alcohol, check glucose, arterial blood gases, ABGs maybe, to check oxygen, CO2 levels, cholesterol. Now, you can measure serum thiamine levels, but the sources stress they aren't always low, and they are not usually needed for the immediate diagnosis and starting treatment.
So don't wait for a thiamine level before treating if you suspect it.
Absolutely not. Treat first. You might also see things like elevated pyruvate or low red cell transcatalyse activity. Those reflect the thiamine metabolism being off. But again, not usually needed for that initial diagnosis.
So the basic bloods are more about checking for other causes of confusion or associated problems?
Largely, yes. And because confusion is so central, you might need a lumbar puncture, LP, a spinal tap if you're worried about a central nervous system infection, like meningitis or encephalitis, which could present similarly.
Makes sense. What about brain scans?
Imaging is definitely useful. A CT head scan is often done acutely, mainly to rule out big structural things like a stroke or a bleed, but it's actually less sensitive than MRI for picking up the specific brain changes of Wernicke's.
MRI is better.
Yes, MRI, especially if you use specific sequences like diffusion-weighted imaging, DWI, is much better at showing those characteristic abnormalities, the damage in the thalamus, mammillary bodies around the ventricles. DWI basically highlights areas where cell damage restricts water movement, making the lesions easier to spot. And maybe occasionally an EEG, the brainwave test, if there's a query about seizures, especially non-convulsive ones, causing the altered mental state.
This really sounds like a time is brain situation. So what's the critical treatment? What do we do immediately?
Absolutely. Time is critical. The immediate absolute priority is thiamine replacement, high dose. And because absorption from the gut can be poor, especially in these patients, we usually start with intravenous thiamine. Get it straight into the system fast.
High dose for thiamine straight away.
Yes. And that's followed by long-term supplementation, usually oral, often as part of a vitamin B complex or multivitamin, pretty much indefinitely, especially if the underlying cause, like alcohol dependence, continues.
And you have to tackle root cause as well.
Oh, definitely. That's crucial for preventing it from happening again. If it's alcohol, that means addressing the dependent support, counseling, maybe specific medications. If it's malnutrition, nutritional support is key. The general approach is treat it as a medical emergency. Patient might need oxygen, IV fluids. You need a team approach, alcohol services, dietitians, social workers involved. You need to keep assessing their cognitive function because the memory problems can stick around. You might need OT, neuropsych assessments to figure out long-term support, living arrangements. Sometimes, early on, legal things like the Mental Capacity Act might even be relevant if someone can't make decisions.
Is there a standard dose for the thiamine?
It's interesting, the sources say there isn't actually a clear universal agreement on the best dose. The BNF, the British National Formulary, which is a standard UK reference, suggests a range, maybe 25 to 300 milligrams daily, depending on how severe it is. When giving it IV, it should go in slowly, usually over 30 minutes, and you need to be ready in case of a rare allergic reaction, anaphylaxis.
Okay. And is there a difference between treating someone you strongly suspect has Wernicke's versus giving thiamine just in case to someone at risk?
Yes, good question. If you suspect or diagnose Wernicke's, you hit them with urgent, high-dose therapy immediately. Prophylactic treatment, giving it to prevent it, that's for patients admitted to hospital who are high risk. Say someone with heavy alcohol use or clear malnutrition, even if they don't have obvious Wernicke's signs yet. Give them thiamine to prevent it developing.
Right, preventative versus treatment dose. Now, you mentioned outcomes can vary. What's the prognosis generally? What happens if they get treated quickly versus not?
The outlook really hinges on that early diagnosis and getting the thiamine in fast. If you catch it early, treat it aggressively. The confusion and the eye movement problems often start getting better within days. But here's another key point. Ataxia, the coordination issue. That often responds less well. It can become permanent, even with treatment.
So the balance problems might stick around.
They often do, yes. And if Wernicke's has already progressed towards Korsakoff's or wasn't treated well initially, those severe memory deficits often mean needing long-term care.
That sounds like a really stark difference depending on timing. What if it's missed entirely, or treatment is really delayed?
Then the prognosis gets much, much worse. The sources state that untreated Wernicke's can actually lead to death in up to 20% of cases.
20% mortality. Wow.
Yeah. And for those who survive untreated Wernicke's, a huge proportion, something like 85%, go on to develop the chronic, disabling memory problems of Korsakoff syndrome.
85% transition to Korsakoff's if untreated. That really underlines the urgency.
It absolutely does. And then of those who do develop Korsakoff's, maybe up to a quarter end up needing long-term institutional care. Recovery from fully established Korsakoff's is poor. Only about 20% ever recover completely.
So the main long-term complication is that progression to Korsakoff's. Are there other problems or complications to be aware of?
Well, beyond the Wernicke-Korsakoff syndrome itself, the amnesia, confabulation on top of the initial symptoms, patients are at risk of complications from alcohol withdrawal, if that's the cause. That can complicate the picture acutely. Recurrences of Wernicke's are a risk if they continue drinking, don't stick with the thiamine supplements, or if other underlying causes aren't managed.
Okay.
You often see persistent neurological problems even if they don't have full Korsakoff's. Persistent ataxia, gait issues, ongoing learning difficulties, memory impairment, just sort of global confusion.
Eye signs, too, the vertical nystagmus might improve, but a fine horizontal nystagmus can sometimes linger indefinitely. And the sources also flag congestive heart failure as another potential complication, possibly linked to thiamine's role in heart muscle function, too. Beriberi, essentially.
Given how bad the outcomes can be, prevention seems absolutely crucial. What does that look like in practice? Well, the most effective prevention is tackling those underlying risk factors. For alcohol dependence, obviously avoidance is the goal, but that needs massive support. For patients with alcohol dependence or severe malnutrition, especially when they hit hospital, giving prophylactic thiamine is a key preventative measure. Don't wait for symptoms.
Right.
More broadly, it's about identifying vulnerable people in the community, people experiencing homelessness, those without good social support, people with severe eating disorders like anorexia, getting them linked in with healthcare, nutritional support, social services. It's a big challenge. Requires a really holistic view.
It really does. You know, considering how absolutely devastating a severe deficiency of just one simple vitamin can be, and seeing this wide range of factors that can lead to it way beyond just heavy drinking, what does this condition really tell us about how we identify and maybe support vulnerable individuals in our communities?
That's a great question. I think it's a really stark reminder, isn't it, that basic nutritional health is fundamental, and deficiencies can have catastrophic neurological effects. It really highlights the deep links between social factors, poverty, housing, food access, mental health, and serious medical outcomes. Recognizing Wernicke's often forces you to look beyond the immediate symptoms and consider the whole person, their whole context, their risks. It pushes us to be more aware, more proactive in identifying and helping those who are vulnerable before things get this bad.
This deep dive has really painted the full picture of Wernicke's encephalopathy, hasn't it? We've gone from the basic definition, the surprisingly varied causes, through how it actually damages the brain, what signs to look for, emphasizing the really key ones, covered the tests, the urgent treatment, and looked at the pretty sobering prognosis and complications. We've tried to pull out all the high-yield bits from the notes for you.
And really understanding these core principles, knowing when to suspect it, knowing to act fast with thiamine, it's genuinely life-changing, potentially life-saving stuff for patients. It's one of those diagnoses you just can't afford to miss.
Absolutely. Well, thank you for joining us on this really crucial deep dive. If you were looking for more resources, maybe some practice questions to help cement this, do check out passmsra.com and freemsra.com.
Yeah, great resources. Definitely worth looking at for revision.
They are indeed. Thanks again for listening, everyone, and we look forward to our next deep dive.